as malignant hypertension in the setting of Queen Mary Hospital, Hong Kong, as you can see in the background. The patient history. The patient was a male, 39 years of age, non-smoker, non-drinker, very untypical for Bulgaria, married with kids, healthy, working as an accounting officer, good past health, no known drug allergies. The family history did not contain any neurological disorders. The mother had, however, hypertension. The patient was under care of neck pain and headache for one day in July 1999. Patient history. The patient complained of sudden onset of headache and blurring of vision. No obvious precipitating or relieving factors, no visual aura, no phonophobia, no photophobia, no nausea, vomiting, no limb weakness or sensory symptoms. Please note, he did not have fever. He attended a private practitioner for his highest BP of 170 by 120. Physical findings, pretty much normal. The patient was alert with coherent speech, oriented to time, place, and person. The extraocular muscles were in full range. The cranial nerves were normal. The tone was normal. The power was full. The jerks were symmetrical and normal to plus with downward planters. The gait was normal and steady. The neck was soft. On fundoscopy, there was a presence of silver wire with flame-shaped hemorrhage and disc swellings or papilledema. The BP was measured to be 180 over 100 millimeters mercury, which is managed well with lipid-dipping SR, metoprolol CR, and lisinopril. The BP gradually normalized to about 130 to 140 over 80 to 100. The patient was sent home and was called later for follow-up for HT and eye care. Investigations. The patient underwent ultrasonography of the kidneys, which are normal. The duplex study did not show any evidence of renal artery stenosis. The 24-hour urine for screening of pheochromocytoma was negative as well. 4 weeks later, the patient had increased blurring of vision for 2 to 3 days. There was persistent headache and neck pain for 4 weeks. Please note again, there was no fever yet again. The BP was 163 or 116. The pulse was 56 per minute, which was regular. The fundi again showed silver wiring with flame-shaped hemorrhage and bilateral papilledema or disc swellings. 4 days later, the patient was under care of diplopia. The physical examination showed left partial ptosis, impaired adduction and vertical gaze of the right eye. There was impaired abduction of both the eyes. The left partial third nerve and sixth nerve bilaterally, pulses were in question. The false localized signs were in question as well. The motor power was full. The normal tendon reflexes were present as well. But now we had positive neck stiffness. The CBP was normal. The ESR was 10. The left by right FT was normal. Anti-DNA, anti-ENA, ANCA, C3 by 4, IgG, IgM, IgA were normal or negative. The CT brain showed nothing as well. There was no space-occupying lesion, nor was there any acute hemorrhage or infarction. Subsequently, the patient underwent lumbar puncture with the neurosurgeon on standby because the opening pressure was greater than 55 centimeters of water. The samples obtained from the lumbar puncture was clear. The protein was 1.7 grams per liter. The glucose was 3.1 millimoles per liter. The blood sugar was 6.8. The total cell count was 76. The monocytes were 29%, whereas the lymphocytes were 69%. The acid-fast bacillus smear was negative. That is, we ruled out tuberculous meningitis. The gram stain was negative as well. The patient was, however, taken to neurological critical care unit for monitoring his increased ICP, that is, intracranial pressure. The CSF was positive for Indian A stink, that is, the presence of Cryptococcal Meningitis. The CSF was positive for Cryptococcal antigen titer with a ratio of 1 to 56. The patient was immediately started on intravenous amphotericin B with a dosage of 0.5 milligrams per kilogram a day, along with 5-flucytosine, 1400 milligrams per 6 hours. Next day, the patient was noticed to have fixed and dilated pupils. The patient was drowsy and had sinus tachycardia with a blood pressure of 124 over 85. In view of the raised ICP of the patient, urgent ventriculoperitoneal shunting was performed by neurosurgeons. The shunt was removed 3 days later with vertigostomy performed to monitor his ICP. The antihypertensives were withheld in view of need of higher systemic BP to maintain adequate cerebral perfusion in patients with high ICP. The patient gradually improved in alertness and responsiveness. The catheter was removed. The BP was kept at about 155 to 180 over 100 to 120. There was full neurological recovery of the patient with a full course of amphotericin B and 5-flucytosine, followed by oral fluconazole. Interestingly, the HIV was negative. The HIV antigens nor were the antibodies present. Differential lymphocyte count was normal as well. Lymphocyte function test showed reduced proliferation of T lymphocytes in response to mitogen stimulation. The patient was not immunocompromised. In conclusion, raised ICP causing hypertension without fever or signs of meningism can be presenting feature of cryptococcal meningitis in an immunocompetent host. Clinicians should consider CNS infection causing raised ICP when hypertension and papilledema are present without evidence of end organ damage to suggest malignant hypertension. Prompt initiation of antifungal therapies is critical for potentially fatal meningitis. Thank you for your attention. Questions? Yes, please.
I have a question. You said that there were a VP shunt inserted in the patient, and I wonder what were the indications? Just the intracranial hypertension?
There was raised intracranial pressure, so that was why the ventriculoperitoneal shunting was performed.
And this was relieved after the shunt was inserted?
Yes, of course.
And were there any collections of cerebrospinal fluid in the ventricles? That's why you did the VP shunt?
Well, the VP shunting is performed to relieve the intracranial pressure. So, as the name says, ventriculoperitoneal shunting, that is the ventricles and peritoneum are connected so that the pressure is relieved. So this is the basic indication in our case. Any more questions? Thank you.